Well, we're going to look at two specific topics today. So the first, I want to focus on the parenchyma of the kidney, and I want to have you relook at the parenchyma as really an indicator of what's going on inside the kidney, focusing primarily on the cortex. The second portion of the talk will look at renal masses. And I want you to realize that in spite of what we've been told previously, not all renal masses are bad. So to begin the talk, I'd like you to look at this topic of renal sinus lipomatosis. And it is one of the reasons why length is not a good measurement of what's going on with the kidney. So renal length is often maintained in spite of there being significant kidney tissue loss, but the length is fine, so we think things are fine. Normal length measurements can exist in spite of significant chronic tissue wasting. Length is not an adequate surrogate for renal status or function. Now, in the kids, it is. So we're talking about adult population. But in the adult population, relying on length alone is going to get you in trouble. And chronic renal disease is often going to be missed if you rely on length alone. When we look at the kidney, we're talking about an entity which is composed of cortex and medulla, which define the parenchyma of the kidney, and then the interstitium. Now, how do you evaluate the kidney? You can evaluate it by length, which we do primarily. We can do cortical thickness, we can do resistive index, and echogenicity. The problem is ultrasound detection of parenchymal disease is very nonspecific. So if you do find that there is a tissue loss in chronic renal disease, the actual etiology is not apparent to you. And it is not going to be apparent without doing a kidney biopsy. And a kidney biopsy is the way to actually establish the etiology. But ultimately, cortical measurement is the simplest measure of the status of the kidney. So let me give you a couple of examples. This is intrinsic renal disease, which would typically, in my experience, often be overlooked. You have a kidney here, which measures 10.1 centimeters. Then you don't see any hydro, and the radiologist might say this is a normal kidney. The creatinine is 7.2. Here's a kidney that the length of the kidney is 8.6, the creatinine is 6.5. Both of these kidneys have decreased parenchyma and specifically decreased cortex. They have increased echogenicity to some degree, and they have a wavy contour. The length is an unreliable measurement here. These are not normal kidneys. You should not call them normal. Intrinsic renal disease, the first indicator is not length, it's loss of your cortical tissue. So instead of having a nice thick cortical tissue here, so you got your medulla at this point, you can see the medulla very well, the arcuate artery, there's your cortical tissue. Here's your cortical tissue in this case. And guess what? The thin renal cortices here give it away. The lengths are the same. Both these kidneys actually measure the same length. And it's the thin renal cortex that shows you there's irreversibility here and chronic nature. With the progressive aging of the population, patients often show up to the physician, and the first time they see a significant bump in the creatinine. Don't forget, you're going to lose over 50% of your glomeruli before the creatinine even begins to move. It's a logarithmic curve. So when you see a creatinine elevation, you are already on the downside. You're in the back nine in renal function. So it's not a good marker. And we often will indicate to the physicians well in advance of their being aware of it that the patient has chronic renal disease. So we looked at a series of patients, and this is published in that article by Beelan, of 100 pre-transplant patients. So these are patients being evaluated, can they have a transplant? So they already have chronic renal disease. The mean length of the kidneys was 10 centimeters. So if you're using length, you're going to miss every one of these 100 patients because they're fine. Instead, what they had was, you can look, they have a length of 10 centimeters, and the typical patient is like this one, 6 millimeters of cortical tissue. That is the parameter that should tell you this is an abnormal kidney. A report saying this is a normal kidney is really missing the mark. So the arcuate arteries are some of your markers. You can easily see those. You see the medulla, and all that sitting out there is cortical tissue. In this same series, we looked at those 100 patients on their way to transplant consideration. The average cortical thickness was 5.9, and the normal should be 10 to 12. So if you're looking at a 5.9 and the length is normal, don't call it normal, because the reason the creatinine is 3.6 is this patient really lost a lot of tissue. So now, just to check and see if we've been staying awake, we're going to go with our first question. So renal sinus lipomatosis is associated with which of the following? Renal hypertrophy, dialysis, diabetes, or parenchymal loss? Parenchymal loss is the key barometer here of why you have sinus lipomatosis. The kidney tries to maintain its size. As you're losing cortical tissue, it fills fat in the renal sinus and you get more fat in the kidney, and the length is maintained. But you basically have a hollowed out kidney with tremendous tissue loss. The other element of renal parenchymal abnormality is echogenicity. So if you see a kidney like this, where the cortical tissue is significantly increased over the associated liver, and the liver tissue looks approximately normal, that's a sign of diffuse parenchymal disease. It doesn't happen that often, though, where it's blatantly abnormal and the cortical tissue remains the same. You can have chronic kidney disease, and for some reason the patient is now being shown up for the first time to the nephrologist, and they want to see if they can reverse anything, and they come to you asking you to evaluate the kidney, and this is a kidney, believe it or not, in here, and it's a small kidney with very atrophic pieces. And in my younger and more naive days, I agreed to biopsy this kidney to establish the diagnosis. And this is the biopsy, and all this green stuff is fibrosis. But this is a kidney that may have a length of 8.2 centimeters, but it's basically a sea of fat, and you see it has decreased cortical tissue, decreased parenchyma, increased echogenicity. All of these are markers of chronicity. And more importantly, the likelihood of treatable disease in these kidneys is so small, it's probably not worth the risk of doing a renal biopsy. So the echogenicity, the loss of tissue, you just tell them, and I would clearly nowadays refuse to do a biopsy in this patient, saying that there's really very little remedial opportunity here. Let's come up down to resistive indices. This is another element that can be utilized to evaluate parenchymal disease. And the formula for resistive indices is pretty simple. It's peak systole over end diastole, or lowest point of diastole, all over peak systole. So if you have no flow in diastole, this will become the number one. So you want to see a lot of flow in a normal kidney in diastole, and the number should be more like somewhere in the 5 to 6 range. The RIs can determine parenchymal disease. About 10 years ago, it was established, if you saw an RI greater than 0.8, there was nothing you could do to make that kidney get better. It was irreversible. It had achieved a point of no return. There has been a rapid increase in the data pointing to that's too high, probably 0.7. So if you have an elevated creatinine or decreased renal function, and you have a creatinine above, resistive index, above 0.7, it well may be irreversible already at that point. This is the markings of resistive indices, therefore, are very important to the clinicians. It's interesting that most of the articles on resistive indices lately are in the transplant literature. And resistive index greater than 0.8, clearly bad. So you got a flow in systole, no flow in diastole. Systole, no flow in diastole. Resistive index is 1 because it's peak systole over lowest diastole, all over peak systole. There's no flow in diastole. And here's a very good article in Radiology a few years ago showing what happens when you have an RI greater than 8. That the vast majority of people are going to progress to continued renal deterioration pretty rapidly within a 2-year period. So if the RI is below 0.7 and you have a good GFR, nothing much is going to happen to your kidney. It will be a normal kidney. You come over here and you start to see resistive indices above 0.7 and a GFR either above 60 or under 60. In both these scenarios, the majority of these kidneys will progress to further renal endpoint, renal damage, more damage or more non-functioning kidney in a 2-year period. So resistive index really has a lot to show. It is associated in some ways to cardiovascular risk factors, and people are actually saying it is a risk factor for cardiovascular disease. Because really what it's doing is associated with systemic vascular disease. If you have resistive index that's abnormal, you're measuring the resistance to flow somehow in the kidney, and it's showing you the same thing your heart's having, your brain's having, and everything else. And it's associated with chronic disease. And believe it or not, this article from Germany points out, it's strongly associated with impaired renal outcome and death. They say it's as good an indicator of impending death as anything. So if you have a resistive index of 0.8, don't sell the guy life insurance. So why is the resistive index not used more? Well, it's extra work. You know, basically you're not going to get more money by doing it. There's a lack of acceptance of RI, mainly because we don't understand how it is related to renal disease. We're not even sure exactly what it shows. It's a very difficult concept. It's often been proven to be normal in certain high disease states. So when you have diffuse glomerular disease, the RI will never be elevated. The glomeruli occupy less than 5% of the parenchyma of the kidney, not enough abnormality to elevate the resistive index. So it's one of those findings in the nephrologist will go, geez, I know the kidneys are terrible, the guys get elevated creatinine, bad renal function, you do a biopsy, diffuse glomerular disease, the RI is normal. Because glomeruli don't occupy enough tissue. And RI is often used in a different scenario with obstruction, where we get such variable results, we've somehow clouded our opinions that it's not reliable. But in chronic renal disease, it is reliable. So question number 2, the specific basis of renal failure is best indicated by which technique? Now we're looking for a specific basis, resistive index, renal length, cortical thickness, or renal biopsy. So renal biopsy is the answer. Renal length and cortical thickness do not necessarily tell you the specific basis of renal failure. They tell you the basis of renal failure. You need to do a biopsy to come up with a specific answer. The next question will be, this is a middle-aged man who presents with acute kidney injury, at least alleged by the internist to be an acute kidney injury. Shows up in the ER, elevated creatinine, no prior medical history. What does this ultrasound indicate? Is it obstruction? Morphologically normal kidneys with a normal RI? Is this a reversible disease? And lastly, is this markedly elevated RI indicating a very poor prognosis? So RI here, now look at this kidney. Many times, years ago, we would have called this a normal kidney. But when we do resistive indices, if you're seeing a resistive index like this is not a good scenario. And you can say, guy's going to go on to chronic renal failure very progressively. They also say by Henny's article that he's likely to die very soon. So these are not good findings to have this. I want to talk a little bit about the incidental renal mass. So half of us over 50 have at least one renal mass. The good news is, majority of these are benign, the renal cysts. But most patients with a renal cell carcinoma are totally asymptomatic. And more importantly, the latest information is at least 25% of solid renal masses are benign. So we've got to kind of reorient ourselves. And the diagnosis of these solid renal masses, the benign ones from the malignant ones, is going to require more work than we can do just with ultrasound. And part of the limitation of ultrasound at this point is the lack of contrast. So the incidence of renal cell carcinoma has been steadily rising. If you really look at the literature, it's not due just to imaging, because we have had good quality imaging picking up 1 to 2 centimeter renal masses for 20 years now, and the rate of renal cells continues to climb. Matter of fact, there's been a 38% increase between 74 and 1990, and it's shown now that the rate is going up at least 3% a year. So it is an imaging, and that's a big component of finding these smaller ones initially. But the overall number is clearly more than that. There is also a much higher incidence in blacks. So cross-sectional imaging showed up sometime in the mid-70s, or the earliest. So go back to 1970. 1970, 2/3 of renal cell carcinomas were found. In those days, they did autopsies. And the average size of the renal cell carcinoma was 8 centimeters. Today, most renal cell carcinomas are less than 4 centimeters when we see them. So the size has decreased immensely. We use CT and ultrasound primarily are the items that find these. CT can depict somewhat smaller than an ultrasound, but it's no better really for characterization than ultrasound, in my opinion. A substantial number of these lesions in both modalities under 1 cm will not be detected. This is a sort of a chilling slide. What's the detection rate of renal masses? And you're breaking it down by size. 5 millimeters, 10 millimeters, 15, 20, 25, 30. And if I had, asked you, I'm picking up anything under a cm, over a cm we can pick up. But this is from the NIH, and look, to pick up 100% of renal masses on CT, you got to be at 2 centimeters. And an ultrasound, you got to be at 3 centimeters with any reliability. So these smaller renal masses we are not picking up And we pick up some of them, but we're not picking up with reliability. Now, the staging of renal cells is really in our favor because the staging, it's not as bad a disease as we had thought. Stage 1 tumors get up to 7 centimeters. So we're detecting most of these now. You can see clearly the data is they're under 4 centimeters. They're in the 3 centimeter range. And 3 centimeters also has this global concept attached to it. Below 3 cms, they're not supposed to metastasize. And allegedly, they don't metastasize. Although if you've been around enough, you know that some of these will do that. But they've taken the number to 7 cms, and really, you have to start to see extension into the vascular components before you call it a stage 3. So our optimal techniques to stage these would be CT and MR, but ultrasound can characterize these very well. Stu Silverman wrote a nice paper a few years ago saying less than 3 centimeters, these small renal masses don't metastasize. That's sort of the focal concept. There seems to be a direct relationship between malignancy and the size of the mass. So if you have a 2 centimeter mass versus an 8 centimeter mass, the 8 is more likely to be malignant than the 2 centimeter. Now, interestingly, we have come up with this concept that it's very difficult below 1.5 to actually often characterize the mass. But I would tell you that if you took the majority of these and you called them a cyst, you'd be right probably 95% of the time again. And below 1 cm almost all the time. But there's no data really regarding this. Instead of saying, you want a follow-up study and somehow people thinking you can't come up with everything, use the buzz term you want surveillance imaging. And surveillance imaging is what we do for these smaller masses under 1.5, where you're really hard to characterize it, and you can actually have the patient come back in 3 to 6 months for the first time and watch it and see if there's any change. And if it stays small, you can get a more prolonged time. But these can be very difficult to characterize. Surveillance imaging for the elderly is even a more suspect phenomenon because now the elderly are defined as the geriatric number is 75. I went to the chief of geriatrics and said, what do you call a geriatric patient? He goes, 75 is the number. The American College, American Academy of Geriatric Physicians call 75 and up. So at 75 and up, interestingly, we found that you're better off leaving these alone. If you have a T1 lesion, no matter what you do, you're not going to help the patient. The length of the longevity and the amount of renal dysfunction we're going to cause by doing a nephrectomy, partial nephrectomy, or even ablation outweighs getting involved. But I can tell you that is not the practice. We have more 75-year-olds who insist they want everything done. We get 95-year-olds who insist they want everything done. So these are numbers you can utilize, but this paper actually says that treatment of localized tumors will not impact the overall survival of patients greater than 75 years, and that's in cancer. And they also point out that 86% of these patients are going to have some decrease in their renal function because they're already so compromised. No matter what you do, you're going to compromise it more. But try to explain it to some of the geriatric patients. Prior practice was certainly one where we said that every renal mass, every solid renal mass was a surgical lesion. And we didn't biopsy those, though. So this is going back as recently as 10 years ago. Solid renal masses would go to the OR. We weren't supposed to biopsy because they caused tract seeding. And also it was felt the pathologist wouldn't always be able to give you a diagnosis. It's funny, we were biopsying everything else, the liver, the pancreas, the lung, but the kidneys were off limits. All of a sudden that's changed. Renal biopsy now has a very critical role in renal mass assessment. And any renal mass that you almost inherently, unless it has all the characteristics, 3 or 4 cms, it's got to come out. But these small ones, 1.5, 2 centimeters, these are not necessarily going to be bad. So when you do a biopsy, you can actually differentiate primary from metastatic lesion, which doesn't happen too often, but might be there. You can actually see these benign masses, and they are a precursor for ablation procedures. So we do many, many ablations of the kidneys, and we don't have tissue yet. And what we found was Medicare in our area will deny payment if we do a biopsy and then send the patient home for the results and then get them back for 2 weeks later to do the ablation. They will deny payment for one of the 2 procedures. Guess which one they usually deny? It's the more expensive procedure. So we have been forced to basically biopsy at the time we're going to do the ablation, have a set of pathologists on site, and get the diagnosis and then proceed to do it. So it's a one-step procedure, which is fine. I'll give you some background. How often can these solid renal masses, though, be benign? And it's common. So Concali wrote 37% of the masses that were going for ablative therapy in the kidney, in his experience, turned out to be benign. So identifying the benign lesion would really avoid doing the treatment. And should you routinely biopsy all masses prior to treatment, if you were purist, you would. You would take no solid renal mass and send it to the OR or to treatment without getting tissue. And in our experience, 27% of indeterminate solid renal masses were benign. The literature would clearly support a 25% number of solid renal masses are benign lesions. In the world of medicine and public health now, we are the Rodney Dangerfield. We are the people that basically they're trying to blame for everything. So this article came out in the American Journal of Managed Care in August. And it's directly related to this concept of solid renal masses being benign. And they pointed out the limits of imaging. Kidneys are removed for benign masses. This ups the cost and the complications. And they came up a much lower number than I've just quoted. Only 1 out of 6, 16% of patients who had their kidney removed for renal cell were later found to have a benign renal process, underscoring the challenge that diagnostic imaging faces. And basically went on to say it's the radiologist's fault. They shouldn't have take the kidney out. And this is costing the healthcare system millions of dollars a year because we're wildly flamboyant in saying the kidneys are malignant. So nothing new. And the real reason why we're so good at making these changes is because of the pathologist. So in the old days, you do a renal mass biopsy and you had an H&E stain. Now they got more stains than I've ever heard of, and I'm sure you're seeing it. There's 3 or 4 pages of path reports with every stain in the world, CKD, and they'll take a mass that didn't know what it was before and tell you it's an oncocytoma. Or they'll tell you it's an angiomyolipoma with no fragment. So it's really a progression of the pathologist that has really allowed so many of these renal masses to be identified as being benign. So concluding the renal mass segment, advances in histology have allowed improved tumor diagnosis. The implications for prognosis and treatment are you've got to make sure everybody understands this is not necessarily a malignant mass, and there's a role for imaging guidance here. And ultrasound is a very good tool to do these biopsies. So in summary of what I've discussed, I think renal Doppler, resistive index, combined with assessment of the cortex is very, very valuable in assessing renal function, prognosis, and impending death. Small renal masses are very, very common. And you're not that great at picking up the real small ones, but they're very benign in up to 25 to 35% of cases, and you should consider biopsy in this scenario.